I'm Dr. Brian Kaufman, a doctor turned patient on the last day of iwCLL in Cologne, Germany. And I'm here with my treating physician for a trial with ofatuzumab and ibrutinib, Dr. John Byrd. Dr. Byrd, you want to introduce yourself?
Yeah, hi, I'm John Byrd. I'm the director of hematology at The Ohio State University, and I have the pleasure of taking care of Brian and a lot of other, CLL patients at OSU.
I heard you say like 400 patients on ibrutinib alone, so you're
That's
doing
correct.
a lot of clinical trials.
We've been very busy with with ibrutinib and the other kinase inhibitors. It's a real exciting time for new therapies that are available for CLL patients.
So what I heard today and yesterday was a lot of controversy about what's the ongoing role of chemoimmunotherapy, the backbone to get really good responses in a specific subgroup of patients with FCR versus people are saying, hey, we've got something new, we need an entirely new way of approaching this. So can you give us your opinion on that and where you come down on that?
Yeah, I think in CLL we're very much at a place where things were at in CML, where when Gleevec came into the clinic, and had been around for about 2 or 3 years. And there was the same debate, and in CML there was a debate about transplant. And do you take people on to curative transplant, or do you do Gleevec and continue Gleevec? And a lot of discussion was around, in the CLL arena at this meeting was, well, particularly for the young people, we have FCR that's working really, really well, and even in a very small subset of patients, the younger patients, who don't have 17p, so probably, and who are mutated, I have IGVH mutated disease, so probably 10 to 20% at most of all CLL patients that need to be treated. Should we do FCR, and is it right to move forward and test these new kinase inhibitors? And I think the people had different opinions, and really, say, for our own group, we sort of fall on the line, that in the context, particularly the context of a clinical trial, going with a kinase inhibitor or a kinase inhibitor with a monoclonal antibody, which is really the only thing that's been shown to prolong survival in CLL, is ethical, because as we learned with CML, if you did Gleevec and went on to transplant later, you did as well. There wasn't a difference. And
So
we
versus
can make
doing a transplant
versus
early
doing a
versus
transplant early.
Yeah.
And so, there's no data right now that if ibrutinib or another kinase inhibitor doesn't work, that chemoimmunotherapy is going to be less effective in the future. And by doing that, as a patient, you potentially take away having to take the risk of the side effects of chemoimmunotherapy, both short term and long term, which, if you're younger, you have more chance of getting benefit from chemoimmunotherapy, but you have a longer follow-up where the long-term side effects can manifest more. So I think people are on different sides, and I think that generally my sense is, as well, is that these agents are new. Not a lot of physicians have given them to their patients, or they've just treated a few people, and and we're inherently biased by the 400 plus people that we've seen that have gone on ibrutinib, most of whom are doing very, very well. And while there's talk of resistance, it's really it's really still relatively uncommon. We're not seeing many cases of it.
So that raises a lot of questions for me. And one of the questions it raises is that ibrutinib or idelalisib are not imatinib. You don't get the MRD negative remissions that you get. And there's often significant disease a year out, 18 months out. How important is that?
Yeah, well, there was a little discussion, by several members of our group alluding to data, that we had, that obviously a lot of the people at the meeting didn't have. But when you look at the people, so we take the ibrutinib experience, and you look at the people that get out a year and have had a partial response or better, so they have just a very small amount of disease, versus patients that have flagrant disease in their blood, which with chemoimmunotherapy in the past, you've seen that, and you'd have thought, we're in a lot of trouble. These patients are not going to do as well. And that's sort of the surrogate, so when people see this, you think, well, they're not going to do well. But when we actually looked at all the people that got beyond a year on ibrutinib therapy, and as to how they do, the outcome of patients who actually have peripheral lymphocytosis is the same, or perhaps even a little bit better. It's not significantly different, but it's at least the same, and actually the curves are better for that patient group. So it really throws out completely a surrogate marker, because that's what minimal residual disease is. It's a surrogate marker for how people are going to do long term. And it's and seeing that people that have a lot of disease that remain on ibrutinib do as well or better than people who have less disease. It's a totally unexpected finding, but it's something it's something that is probably telling us this drug is really hitting a very, very important target that CLL cells need. And say without this target, the CLL is incapacitated, and these cells that are floating around really, in the end, at least at this point, with the follow-up that we have, really don't seem to matter.
Let's take a pause there for a second, and we'll pick it up in a minute.